Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
Hello and welcome. Today, we're going to dive deep into the pharmacology of chronic obstructive pulmonary disease, or COPD. We'll be breaking down the core drug classes, how they work, and how they're used in the real world. This is absolutely essential stuff, not just for your exams, but for taking great care of your future patients.
So here's our game plan. We'll start with the basics of what COPD actually is, then talk about what we're trying to achieve with treatment. From there, we'll get into the nitty-gritty of the drugs themselves, bronchodilators and anti-inflammatories. We'll also cover what to do during those sudden flare-ups, and then wrap it all up with the key principles you need to remember.
All right, first things first. We have to understand the disease before we can even think about treating it. Getting a solid handle on the pathophysiology is the key to understanding why we pick the drugs we do.
So, what is COPD? Well, at its core, it's a chronic disease that gets worse over time. The main problem is an obstruction in the airways, that is, and this is a key phrase, poorly reversible. It's often caused by irritants like cigarette smoke, and what happens is that air gets trapped in the lungs. This makes it really difficult to breathe out, and that's what leads to those classic signs, a productive cough, wheezing, and that feeling of being out of breath that just keeps getting worse.
Now, COPD isn't just one thing. It's really an umbrella term for two main conditions. First, you've got chronic bronchitis. Think of this as the mucus problem. The mucus-producing cells in the airways, the goblet cells, get bigger and go into overdrive. Then you have emphysema, which is a destruction problem. The actual lung tissue, the delicate sacs where gas exchange happens, gets destroyed. And in reality, most patients have a mix of both.
And here's a super important point, especially for your exams. While smoking is far and away the biggest cause of COPD, you have to remember the genetic link. A deficiency in a protein called alpha-1 antitrypsin is a major cause of emphysema. This is that high-yield fact you'll see pop up in questions about younger patients with emphysema who might not have a long history of smoking.
Okay, let's switch gears and talk about our goals. When we give a patient these medications, what are we actually trying to accomplish? Knowing our target helps make sense of the entire treatment plan.
So, here are the main goals. We want to help patients manage their day-to-day symptoms, like breathlessness. We want to cut down on the number and severity of those flare-ups or exacerbations. And ultimately, the big picture is to just improve their overall quality of life. It's really important to know, though, that only one thing has actually been shown to help patients live longer, and that's long-term oxygen therapy.
And this is a really critical point for setting realistic expectations. The drugs we're about to talk about, they're great for making people feel better and preventing flare-ups, but they don't cure the disease or fix the damage that's already been done to the lungs. And aside from that oxygen therapy I just mentioned, they haven't been shown to extend a person's life. Our goal here is management, not a cure.
Let's get into our first major drug class, bronchodilators. These are the absolute cornerstone of managing COPD symptoms because they directly attack the problem of tightened airways that makes breathing so difficult.
We've got two main types of bronchodilators in our arsenal. First are the inhaled beta-2 agonists, which work by relaxing the smooth muscle around the airways. Second are the inhaled antimuscarinics, which block the nerve signals that tell the airways to constrict. Now, what's really interesting is that in COPD, the antimuscarinics are often even more effective, especially in patients with that chronic bronchitis picture. And of course, we can use them together for a 1-2 punch.
Okay, this is a fundamental concept. You have to know the difference between rescue and maintenance therapy. Your short-acting drugs are your rescuers. They're used as needed for a sudden attack of breathlessness. The long-acting drugs are for maintenance. A patient takes these every day on a set schedule to keep the airways open around the clock and prevent those flare-ups from even starting.
Then there's this older drug, theophylline. It's kind of unique because it does two things. It acts as a bronchodilator, but it also has some anti-inflammatory effects. The big exam pearl here is its relationship with glucocorticoids. It actually boosts their anti-inflammatory power, which makes it a pretty useful add-on for patients who just aren't getting enough relief from their standard inhalers.
All right, opening the airways is only half the battle. We also have to deal with the inflammation that's constantly simmering in the background and driving the disease. This brings us to our second big category, anti-inflammatory agents. Glucocorticoids are our heavy hitters for inflammation, but how we use them really depends on the situation. During a bad flare-up, we need a powerful, system-wide effect, so we'll use oral pills like prednisolone or even IV methylprednisolone.
But for long-term day-to-day management, we use inhaled versions. This lets us target the lungs directly and helps avoid a lot of the systemic side effects, with the main goal of reducing how often exacerbations happen.
Now for something a bit more targeted. This drug is called roflumilast, and it's a PDE4 antagonist. Let's break down how it works. There's an enzyme called PDE4 that breaks down a molecule called cyclic AMP. By blocking that enzyme, roflumilast causes CMP levels inside the cell to go up. And what does that do? Well, in inflammatory cells, it calms them down. And in smooth muscle cells, it causes them to relax. So you get this great dual effect of less inflammation and less bronchoconstriction.
But that unique mechanism comes with some pretty specific side effects you need to be aware of. GI issues like diarrhea and nausea are really common. But the ones to really watch out for, the ones that are classic red flags on exams, are the mood and behavioral problems. We're talking about insomnia, anxiety, and even depression. You definitely need to know that association.
Okay, let's shift our focus to those acute exacerbations. These are the sudden flare-ups that can be really dangerous for patients and are a huge reason why they end up in the hospital.
So what do we do when a patient's breathing, their cough, and their sputum production all take a sudden nosedive? More often than not, there's a trigger, and that trigger is usually a respiratory infection, either from a virus or bacteria.
And that brings us to antibiotics. So when do we use them? The key sign to look for is purulent sputum. That's sputum that looks like pus. If you see that, it's a strong sign that bacteria are involved and it's time to start an antibiotic. The specific one we choose, whether it's amoxicillin or something like azithromycin, really depends on what bacteria are common in the area and the patient's past history.
You know, this right here highlights one of the most important ideas in managing any chronic disease. Prevention is everything. Since we know infections are a huge trigger for these dangerous flare-ups, one of the best things we can do is stop them from happening. And that's why getting a flu shot every single year is an absolute, non-negotiable standard of care for every single person with COPD.
Okay, let's wrap this all up. We're going to pull everything we've talked about together into the core principles of how we manage COPD.
So here's the summary, plain and simple. We use bronchodilators to open the airways and make breathing easier. We use glucocorticoids to fight inflammation, both during flare-ups and for long-term control. We have add-on drugs like PDE4 antagonists for tougher cases. We use antibiotics to treat infections that trigger exacerbations. And finally, we use oxygen, the only therapy proven to help patients live longer. Each one has its own specific job to do.
And that leaves us with the million-dollar question, doesn't it? We've just gone through this entire pharmacological toolbox, but how does a doctor or a nurse practitioner actually choose the right drug for the right person at the right time? Well, that is the art of medicine. It's about taking all this knowledge and applying it to a real person, crafting a treatment plan that's tailored just for them. And truly understanding these principles, well, that's the first and most important step you can take.